Good morning, everywhere. Thank you for coming. And as Peter say, today we talk about decide. What mean decide for patient? What mean decide or help to decide for patient advocates? What mean decide how the physician share the decision making with the patient? How is possible? We need to explore with Professor Ken Bennett. You know, this yesterday I don't introduce anywhere today, but please, if you come to share your opinion after we introduce the other speaker.
We'll also at this time invite up the panellists for this session. So supporting Professor Kennedy on the stage today is also Raymond Vles from Canada and Shova Karki from Nepal. So if they wanted to come up to take a chair as panellists. Raymond is the chair of CLL Canada and the facilitator of the Quebec CLL support group. Having experienced both thyroid cancer and CLL, Raymond brings the patient's perspective on ensuring voices are included in care planning and on the importance of advocacy in treatment access.
So that we're facing the
Yeah.
audience.
Shova, not online. Oh, okay. So Shova is online. I'm hoping So Shova is an advocate and leader of the Blood Cancer Society in Nepal. Due to political issues in Nepal, she's unable to be here with us in person, but we'll connect with her virtually. A survivor herself, Shova has dedicated her efforts to supporting patients and caregivers and raising awareness and creating networks in resource-limited settings. I can see you now, Shova. Hopefully like yesterday, we have the ability to have her up on the screen as well. There she is. We can now see you. Can you hear us all right, Shova?
Hello everyone. I'm here listening. I'll talk when I'm called up. Thank you.
So Ben, did you want to start and talk in your space and from your experience
Thank you
the
very
shared
much.
decision making? Yeah.
So we have. Thanks very much, Catherine. It's great to be here. Thanks for this really kind invitation to talk about shared decision making in the clinic. I think we have 50 minutes for this session. Now, I have no intention of talking for 50 minutes, and I've got notes. So I hope that it will make sense and that we will explore some of the issues around shared decision making. It's still a relatively new concept, I suppose. It's not been around for decades. This is something that we're growing into, exploring and understanding, and is not a fully formed thing in any way in my experience. We know that fewer than half our patients feel that they're involved in the treatment decisions that they need to be involved with, and that there is a very strong element of doctor knows best and this is the treatment that you're going to have, without a sort of fully formed sort of opinion involving the patient. It requires an understanding on our patient's part of the options available and what the practical consequences would be of any treatment options. And that requires information, which is, that needs to be accessible, that needs to be readable and understandable. So there's a whole thing we've become to learn about quality and trustworthiness of information. But there's also a very strong element of preference. And what does preference mean? And how can we help our patients to understand how to articulate a preference? And it's not a superficial thing. It's quite a deep thing. And of course, we cannot escape from an element of guidance. There has to be that medical guidance as well, that comes from us as clinicians in the widest sense, including our nursing colleagues, about the nature of treatments and how it impacts on our patients' lives. So giving that guidance, it's really essential that it includes clear information about effectiveness, benefits, and the harms that go with the treatments that we're talking about. So we've kind of moved through that whole active monitoring situation. We are now at this crisis point. So whatever work has been done in the previous months and years leading up to this, let's hope that it has really set the stage in both our minds and in our patients' minds and their carers, their families, and with the people that they live and work and love. So patients then will already, one hopes, have had the opportunity to reflect on their own personal circumstances, how mobile they are, their attitudes to illness and risk, and what their values and what their preferences are, and how we talk about that. So as I say, preferences, it sounds superficial. It says, oh, yes, doc, I would like treatment A. That sounds nice. I like the name. It should not be like that. It must not be like that. So how can we align preferences and match them up to a clinically valid, responsible, appropriate treatment option? So the options then need to be spelled out. So, if you're a young person with otherwise biologically favorable disease, you might want to have a conversation discussing the merits of a time-limited therapy, for example. Or if you're a frailer person with comorbidities, then perhaps a continuous therapy might be something that could be more appropriate. And these are things that, as clinicians, we begin to explore and give emphasis to, but in the context of what our patients would like to fit into their lives. There is no bad choice with our treatments here. Okay? There is no bad choice, but there could be better choices, more appropriate choices, and there may even be let's do nothing choice. How frequently am I surprised by what my patients tell me about their attitudes to their illness, their risk, and their choices? It does, and that does happen. So there's an element of delegation of responsibility, right? So I have that responsibility to explain clearly, identify the timescale. A window of opportunity begins to open up as treatment becomes more appropriate. I can see the hemoglobin dropping. I can see the platelet count dropping. My patient tells me they feel less well. I can see the lymphocyte count doubling too rapidly. It's not about absolute numbers. We're not going to go into the details of treatment triggers in this discussion. But we can anticipate it. And it begins to open up in front of us and we say, there's a landing zone here somewhere. I think it's going to be early next year. I think you're running into trouble and we need to talk about it. So you can set the scene quite early on. So in many ways, there is a wonderful opportunity for our patients to talk through things with their families, to work out what's important to them and to set their priorities and to articulate clearly those back to us. But with that comes a responsibility to accept some of those decisions that our patients will be making. It's not on them to choose, but it's on them to seriously consider what is right for them and their lives. So talking through the goals, what do you want to get out of this? And that might be a family occasion, it might be going back to being more active, it might be very basic things. I just want to be up and about, I just want to have a better quality of life. I want to live longer, I don't want to die. There's lots of goals that people will have, both said and unsaid, that I think we can help our patients to articulate, not just me, the wider team. And those those preferences can sometimes highlight gaps in our understanding. So I think that my patient needs this, and they tell me that they want that. So we don't always immediately have the same ideas, the same goals. They can be different. So there can be those gaps in understanding of what would fit into somebody's life. So I can't assume anything about it. And, you know, for that reason, you know, exploring it together becomes an essential part of it. Surveys tell us time and time again that people want to be more involved in those decision-making processes. The benefits that it brings, for example, is fewer regrets about the choices. So if you're a stakeholder in that decision, then it's much more likely that you're going to engage with it and be more compliant with it in the first place and be more satisfied with the outcomes. I chose this. This was me doing something for myself. How great is that? Look, I almost cured myself. I almost treated myself. I'm in remission because of the decision I made. Okay? That's part of some of the things that I hear. And the relationship of the patients with their families can improve and be fostered, encouraged. The relationship between patients and the healthcare providers, the clinicians around them, can be fostered and encouraged through this process. So it's personalized. There's a bit of legislation. Now, I was working for a long time in the UK, and there is law, there is case law. So there's no reason why you'd be familiar with Montgomery versus Lanarkshire, going back to 2015. And this is a case that was held up in law about how much information should people have about the nature of treatment and the risks around it. And it moved that center of gravity of opinion about what is important, about the nature of side effects and adverse effects of treatments, from the treating clinician to a representative, reasonable patient in that position. So in other words, there is a legal duty that the clinician must take reasonable care to ensure that our patients are aware of all material risks and alternate treatments. And those risks are not defined by me. In law, they are defined by the body of patients. And that shifts that perspective of what is relevant, what is important from us, and it's given back. I don't know whether it's given back, but it's given to an extent too. Because wresting that control from us is a lifetime's work, and how much resistance is there from us in giving away our control over medical situations. But that is the direction of travel, and it's something that we need to identify and push forward with. There's issues around mental capacity, because the ability to weigh up and sort and remember and analyze information will vary very highly from one individual to another. While there is a broad range of normality, there are some people who do not have those fundamental capacity to be able to weigh up information to make those decisions. And that needs to be taken into consideration. And people still know what's important to them. People still know what they like. They still know what they want. And so that needs to be taken into consideration. Okay. So there are nice guidelines produced. So NICE is the National Institute of Clinical Health and Care Excellence in the UK. So it's a body that looks at evidence bases and gives significant guidance to clinicians and to commissioners about prioritizing healthcare. It's a very useful political body and economic body in the UK. So in 2021, they brought out guidance, official guidance on shared decision-making. And importantly, it focuses on organizations, and it's not something that we necessarily have touched on significantly at this meeting so far. We've talked about the interplay between clinicians, between advocates, between patients, families, carers, and it's quite granular. But the culture in which we work, the organizations in which we are embedded, are essential for providing the milieu, the environment in which we work, and the resources and the limitations placed upon us. So if I have 15 minutes for a consultation, that's because the organization says I have 15 minutes for a consultation, even if it requires something more. And if there are not resources such as clinical nurse specialists outside the clinic to whom my patient can turn, or advocacy groups that are within easy reach, then those things are organizational, and the guidance does, to an extent, focus on how to embed influence and influential voices at board level, at commissioning level, for example, that will then improve how we can deliver those aspects of patient care, so we can spend the time that we need. And we've spoken about time frequently. How can we do this? It's a luxury. We haven't got that time. There's a reason for that. Raising the profile of service users within those organizations then increases the focus, and specifically there are difficult to reach groups which can be championed through that, whether that's ethnic groups or whether it's gender groups. I mean, famously, it's harder to reach men, and it's just a fact of life. We don't always want to know. It's just one of those things. And we don't always talk as much.
Ignorance is bliss.
So they say, I wouldn't know. Healthcare providers. So, does each of us have the knowledge, the skills, the competency to be able to deliver this? So there are issues around training and development of individual clinicians to encourage people to really talk about what's important to our patients in clear language, avoiding jargon, signposting to trustworthy information, and communicating clearly with patients and carers. For patients, it's encouraging powerful questions. What are my options? Make it clear. What are the benefits and the risks? How do we decide together to do these things? And that challenges us then to respond to that meaningfully. What are my options? Do nothing, this. And it has to be laid out. And what is it? What are the implications, the practical implications? How do we include family and carers and advocates into the system? So the advantage is that this encourages units of people to engage, to explore what matters to people. So, Grandad, you still enjoying your golf, or you love going down to that cafe and meeting your friends. All these things are important. And you say, oh yeah, I'd forgotten that. I meet up with old so-and-so every week and we have a coffee and a chat. I really enjoy that. I haven't done that for months. That's important here, isn't it? Yeah, I'd like to do that again. So there could be specific examples of what somebody wants to get out of treatment, not what I think they need to get out. Your hemoglobin is too low. I want your hemoglobin to be 12, 120, whatever units you want to use. Yeah. Okay, that's not really a goal of treatment, is it? I mean, who am I fooling with that? It's not. What is meaningful?
Oh, okay. You finish?
Do you want me to finish?
No, I asked you.
I'm not finished yet.
Yeah.
But how much time have we got?
No, zero.
Zero time.
Zero
Oh, that's fabulous. Okay. Chunking information. Give me 30 seconds.
Yeah.
Chunking information, breaking it down, agreeing what you can talk about at the next time. Talking about risk, people have different attitudes to risk. There's a risk barometer. I say to my patient, look, different people worry about different things. Are you one of those people that appreciates the risks that you take in life? What do you do? What kind of sports do you do? What's your background? All those things can be really interesting. We need to summarize what we've talked about. We need to agree next steps and letters. So the academic Royal Colleges brought out some guidance to us for writing letters, and certainly in the UK, letters habitually will go to the patient with a copy to the GP, with the proviso that this is what my patient wants to have, and with the proviso that I say to them, look, we have discussed, these are the things we've discussed in the clinic. I will send you a letter that outlines all of this. There will not be any surprises in your letter. So don't put surprises in there. Don't fill it with jargon. And, it can be very empowering to have some of the specifics and the technicalities, but it can also be written in plain language. And I think that has improved communication and understanding to both patients as well as to GPs who understand their patients and that shared care aspect better than the letters that they were getting, which would have been just a list of diagnosis, drugs, and when we're going to see them again. So I can stop there.
Thank you. You give us the perspective of a physician in decision making, but we would like to understand with Raymond the point of view of the Patient Advocates Association, how we can help patients who are aware, empowered in the decision for disease. Please, the floor is yours.
Thank you. And tell me when 10 minutes is up, please.
Exactly.
Because, once one starts talking. So I'm with a small organization in Canada called CLL Canada, and our origins is as a conference organizing committee. So I think we organized our 6th conference last spring, but it began as a conference organizing committee and slowly became an organization with a big focus on information and some advocacy. So I'll talk mainly about the information. And I guess we all know that, for shared decision making, you need a knowledgeable patient. And also we think patients, more knowledge gives you a feeling of control over your situation as a patient, and you know more of what's happening. So it's good for the mental health, and it's good for shared decision making. With the internet, there is a lot of information out there in English, and particularly in English, and some of it's good, and some of it's bad, and some of it's out of date. And when you have a particular question, it can also become difficult to find. It's like looking for a needle in a haystack. And so that's that phenomenon, and it's particular to English because so much on the internet is English. It's different for other languages. Really has shaped our approach. And so we have tried to focus on information that we think that patients are looking for, practically oriented information, things that will help them manage and deal with their CLL. And we give that or provide that to them. We have a website, we have a bulletin, and we've continued with our conferences. And I'll talk mainly about the website and a bit about the bulletin. So the pandemic, I guess, was an occasion for us because we couldn't do a conference. So we really focused in on the website and tried to, we created what we call our Information and Resource Center, which is really a page on the website, with a series of drop-down menus organized by the stages in the patient journey. So just diagnosed, watch and wait, treatment issues, living with CLL, side effects, and also some menus around around family issues, financial issues, etc. And rather, since we're an all-volunteer group, we don't have staff, we don't have an office, and rather than write all this material ourselves, what we did is we combed the internet and selected what we thought was the most interesting material. We had a committee of our board members that looked at this, and we've basically linked to lots of existing resources on the internet. We have a little descriptive paragraph on each link in each menu, which is divided in subtopics. Our poster is back there, and there's a QR code if you want to go see the page. And in that way, it helped us, it enabled us to really put a lot of resources available without having to write all this stuff from scratch. And it also gives us a whole variety of different approaches to the same subject, because as you know, it can be quite complex, and there are different ways of looking at things, different ways of expressing and describing side effects or treatments or what it's like to live with the disease or the issues. And so we get all sorts of different perspectives in that way. So that has been, that's really been an important part of us. And I think since we've done that, I guess since the beginning of the pandemic, we've pretty much doubled our number of what we call our subscribers, because they're not really members in the sense they have a membership card, but we've really doubled. So we think we're doing something that people find valuable. Okay. Oh yes, and also we have Canada, as you know, there are 2 languages. In the province of Quebec in particular is a lot of French speakers. And so we've been struggling with how to move this into French. And thanks to some help of people who know more about the web than I do, we've been able to build a French site and kind of a parallel site. And for the English links, the links which are mainly in English, we can integrate a Google Translate link so that the page opens up translated for people who don't read English, and they can see it in French. So that's interesting. And Ross, who's back there, can explain to anybody who wants to know the technical details about how to do the Google link, because don't ask me. That's all I can say. So along with that, we also have a bulletin which we send out every couple of months with 2 articles, and we use the same strategy. We find interesting things on the web, things that we think are of practical interest to somebody dealing with the disease, whether it's communicating with the doctor, whether it's something on side effects, or some information on secondary cancers, or a range of topics. And again, we do a summary. Summaries of the article is on our webpage, and people can click through to the original if they want more details. And finally, we have our conferences, which we are continuing, which we're now going to try and do on a more regional basis, Canada being a big country. So that's essentially what we do, and that's really our contribution, is to be a resource center, an information center for patients who want to learn more. And it's a beginning place where people can go find the information that they need. And hopefully we've made that our aim is to make it easily accessible, easy to find, and quality information. And those sites that we link to are often sites that people can explore for more information. So that's it.
Thank you. I agree with you, because knowledge is the way to empowering the patient and the knowledge is important, because otherwise the patient is no actor of their disease. But now we have Shova is with us, please, on the screen. Thank you. And I ask to Shova, in your country, in your experience, in your region, how you support patients to make decision in a country where not all drug is available, with the access is not for all people. how you empower the patient, how you use, which tool, which system you use for this. Thank you.
Hello, am I audible?
Yeah.
Yeah. Okay. Good morning, everyone. Though it is already known here, I'm Shova, a patient advocate from Nepal. Today, I was supposed to be there in person for this session, but because of the worst condition of my country, I could not come there. I am thank you for the management team who made it possible for me to get connected with you through this way. This is my first time speaking English as a speaker, so though I'm not that good in English, so quite nervous too, but thanks to this virtual platform where I'm finding comfortable. Please forgive me if I make any mistakes.
No problem. This is bad English for us.
Before jumping on this topic, I would like to share small information about my organizations. We started in year 2007, primarily focusing on the awareness, but with the passing time and the demand of help, we started helping patients in their medical tests, and now in the plan to broaden our area for other patients too. Now, continuing to the topic I'm given to, first I would like to share that I'm in this field for a quite long time, volunteering as a patient advocate. This topic, shared decision, strong world outcome, has been a very good topic and very close to my heart, and I always love to speak about because I strongly believe in it. Through a journey of myself being a patient, I have realized how important it is for the patients to get correct knowledge and be the part of decision. We all know how frightening the word cancer is, and patients feel totally lost. But when the people living in on the developed country like mine face cancer, the treatment cost becomes the most frightening nightmare than the cancer itself. When we visit doctor and hear them talking using medical words, which they can understand, this makes them even feel more helpless. At that moment, the only thing patient want to know is what is happening to me and what treatments options do I have. In this situation, when doctor explains things in simple language, listen to the patients, answer them with their queries, both the patient and caregiver feel stronger and stands ready to face what comes next. This helps them to take the right steps and stay positive during the treatment. I don't know how the treatment happens in big countries, but in my country, where many patients are uneducated, they just do whatever the doctor says. They never ask questions. Even educated families, I have seen them just following what the doctor tells them, maybe because they are nervous or scared of the disease. When I meet patients in the programs or when they come to us for the help, I try to talk to them about their diagnosis. Many times it makes me feel sad because some has a little knowledge about the disease where some doesn't know what journey they are already in. Many of them do not know how longer the treatment goes and what financial burden they have to face. Saying this, I am not trying to say doctors are wrong. I respect doctors and I strongly believe on them because they always want the best for their patients. But what I want to say is treatment is not only about taking the good medicine and go to the expensive hospital. For patients and caregivers, it also means of heavy financial burden as well as emotional burden. That is what we can just ignore. So for me, shared decision means doctors should share every information in detail and honestly so that patients can understand what is happening to them. At the same time, patients should get a chance to share their worries, their lifestyle, so that doctor can better understand their situation. Both the parties should respect each other's decisions. Also, as a patient advocate or a caregiver, we can play a big role in making things simple. We can make resources available in the simple and local languages so that people can understand. We can make booklets which is patient friendly. We can make a group where we can share our experience. We can organize doctor patient meet where each other can answer each other's questions. In this topic, I want to set my journey as an example because I have already gone through 2 treatments for cancer. I was educated, so I never left a chance to know about my disease. But anyways, my first journey was with CML, which was started in 2002. I have undergone medication for a long time. I had struggled so many side effects during the treatment. Even that treatment started giving me the good results within 2 years of the medication. During my follow-up, I asked my doctor if I can quit my medicine. At first, he said no. I do understand his concern and worry, but all the same, I could not deny what I was going through. After a long conversation and promising to follow up carefully, he allowed me to stop. Today, even after a decade, I am without a medicine. I am doing well. Unluckily, I faced a second cancer in 2019. I was referred to a doctor, but his advice didn't convince me because he was briefing me about the old treatment, whereas I have known many treatments that is already going abroad. So I changed my doctor because I was not convinced. I was lucky that I find the right doctor for me. He explained everything: the disease, treatment options, cost, medicine options, and its effectiveness, and about health insurance too. Because of this, I could make my own informed choice about unnecessary financial burden. And today, as you can see, I'm strong and healthy. During my advocacy session, I visited the doctor. I heard some conversation between doctor and patient. Patient was in worry, sharing that now he has no financial support to extend his treatment, and the doctor was answering the doctor questions. Do you have your home? He said, yes, I have. And the doctor said, sell it. That was the fearful story I have been through during my advocacy time. So I literally feel that doctor and patients should come to a single ground and make the decision that makes the treatment goes best. To finish, I want to say knowledge is not a power, it's a hope. When patients are informed and included in the decisions, they feel respected and they feel less alone in the journey. Thank you so much. Thank you so much to the management team and everyone.
Thank you so much, Shova, and that was such beautiful words. I guess what I've heard this morning across these astute speakers, and Ben shared with us, his experience of building that trust and relationship and working towards shared decision making and some of those key factors in establishing. And I guess, what I really took away from your space, Ben, is while you're sharing this information, at the end of the day, it's not a one size fits all, and there's a personalized approach, and over time building that relationship with the person sitting in front of you around what matters most to them, which I think you picked up on as well, Shova, that it is not just about the medicine, it's the impacts outside of the treatment that's being spoken about, the challenges of culture and language, and making sure that that relationship starts building on those things that matter most to the person. Ray, and thank you very much for sharing sort of the insights of CLL in Canada and what strategies are being put in place to put those pieces of information in the hands of patients so that they can walk into sessions and appointments with their treating team to talk around what they want to ask the questions of and feel empowered through that information to start building that relationship with their treating team. One of the things that you picked up on, Ben, spoke to around guidelines that exist within the UK sector to help support and elevate what good shared decision making looks like. And I'm mindful it was great to hear from Shova around her experience in that real life. And I guess, I'm going to take liberty of being in the chair and sort of say, we all know what good looks like. And you mentioned, Ben, while this is what the guideline talks about, patients potentially are walking into really busy centres where time, the doctors are running behind, and, the longer you're waiting in a waiting room, the more you're aware that the doctor is running behind and your time doesn't necessarily feel valued. So keen to hear from sort of, whoever wants to take the mic around, what good looks like versus sort of, I guess, that experience and maybe Raymond, what you have done to make the most of that time to make sure that you get what you are walking into and can walk away with that sense of feeling like you were empowered in that conversation.
Well, in terms of seeing the doctor and making the most of it, well, one of the things we in our support group sometimes have patients who complain about fatigue and side effects, and they're in watch and wait, and the doctor just says, no, you're not ready to be treated yet, and forget it. So what I talked to my own hematologist about that, and I had a real insight when I told him about this, and he said, well, fatigue, I could ask any of my colleagues around here, and they'd say they'd be tired. So that was that's how the doctor sees it. So I've become quite interested in trying to understand as a patient how doctors see things, which is not the same thing as how we see them. So the advice that we give in our support group is document. Each day, if you're tired each day, document it each day. If you have infections, when you get them, how long they last, or what the symptoms are, and show it to the doctor, because at least it's data. And it's not just your opinion. And hopefully that the doctor will take it more seriously because you're providing data to him or her. So that's one of the things that we say.
Shova, is there anything that in your space that you help support people in their preparedness of going in and having conversations with their treating team?
Yes. From our organizations, what we basically do is we have form a WhatsApp group, and so that every patient can share their experience. They can share their side effects. They can talk about the side effects and the treatment run to them, so that each other can help each other. And also, as an organization, what we do is like we set up a meeting naming a doctor-patient interaction program, so that whatever questions the patients have, they can directly ask with the doctor, and then they can answer. Then the doctor can answer them with their queries, because what we see is generally when we visit a hospital, there are so many patients. Doctor cannot give a patient half an hour time when they visit, because they are quite busy. So if when we arrange this kind of meetings, whatever queries that patient have, they can express before the doctor, in front of the doctor, and he will respond back in that case. Sometimes the patients approach us and ask questions, because as we are working as a volunteer, they ask questions. Whatever questions we get, we answer them instantly if we have related answers. Otherwise, we collect the queries, make a time with the doctor, and answer them. This is how we are helping.
Thanks, Shova. I'm mindful of time. While our clock says 5 minutes, it's actually behind. Was there any? We have time for a question. I see.
In the back. Please, Mike.
Nick, would you be able to run the mic for us?
Hello all, and it's really nice to see Shova participating this virtually. And I very closely work with Shova in Nepal, and she is one of the very active patient leader, no matter whatever she personally going through, but she makes sure that she care for the patients in Nepal. As she mentioned, there is a WhatsApp group, and she's pretty much very active, guiding the patients how to be compliant, how to focus on the treatment journey, and couple of times there were situations where patient speak about medical related queries, where I have seen her coming with a very firm answers like, this is not a platform where you share your medical related. Please do go to your physicians. And I appreciate that she participates, she organizes patient support group meeting. We have 3 institutions in Nepal where Max partner institutions. And now there was a meeting which she had been, and there is another meeting which is coming up for World CML Day, and she is the one who's in the front managing the meeting, organizing. As she said, we always have a patient and physician interaction sessions where it's an open platform, and that is the time where patients open up with their queries. No matter, it can be at time very stupid, but we support them, providing that platform where they can ask anything, and the physicians also patiently respond to the repetitive questions they ask. And she is the one who manages the entire patient support group in Nepal, where we have around 14 programs, and all the patients are, like when we enroll their patients to a Max program, it is mandatory that they have to be a part of the WhatsApp group. And then our role ends as Max. And then it is taken care by Shova, and there are other very active members from Nepal. They are managing it very beautifully.
Thank you.
Thank you. And I think I was actually going to close this session with a quote from Shova that I have taken from your session, and thank you so much for sharing that. You know, this session that we have right now has really highlighted the importance of the relationship in that shared decision making. And the next session that we talk about will then branch into the importance of health literacy in building towards decision making. But importantly, I think the take-home message for all of us in this room, and the roles that we play to support people in empowering them to have those conversations with their treating teams, is it's not about power, it's about hope. And Shova, that really resonated with me. So thank you for sharing your insights with us. And thank you also to Ben and Raymond. Yes, Shova, sorry.
Before you jumping into another session, I want to thank Salini for helping me clear out everything. Thank you so much.
Okay. Thank you.
Thank you.